You just want to, presenter mode. Perfect. All right. So this is going to be our last presentation of the day. Joel Noble. And Joel's project is titled The Use of Deep Learning to Generate Synthetic CT from Diagnostic CT for Expediting Palliative Radiotherapy. So Joel, take it away when you're ready.
Cool, yep, thank you, Jake. Yes, so exactly the title of my proposed research is The Use of Deep Learning to Generate Synthetic CT from Diagnostic CT for Expediting Palliative Radiotherapy. And a big thank you to my supervisors, Jake Kendrick, Pejman Raushan Farzad, Suki Gill, Branimir Rusinov, and Milad Mirzay. I'm very thankful for their support and look forward to working with them more throughout the coming year. And getting right into the aims with a bit of background as well. So the current radiation therapy workflow can broadly be segmented in three ways. So you have your diagnosis and consultation, followed by treatment planning and then treatment delivery. Now the research I'm going to propose will target the interface of segments 1 and 2. So the current palliative radiation therapy workflow at Sir Charles Gairdner Hospital is that patients are required to come in for a dedicated simulation session. So that is where you'll get a planning CT of them to base their treatment upon. Now, what if you could take their diagnostic CT used for their referral, which has the characteristic curved couch, and use deformable image registration in such a way that it could resemble what the planning CT looks like with the flat couch. So to achieve this, the three overarching aims are to perform deformable image registration and extract the deformation fields resulting from that, and then perform deep learning using these deformation fields as the ground truth data set, and then evaluating this model. And that will involve applying the produced deformation fields to test case diagnostic CTs and comparing the synthetic CT with the original planning CTs. So why is this significant? Well, for palliative patients, they have a median life expectancy of 5.6 months, and on top of that, they suffer debilitating symptoms such as severe pain and even compression of the spinal cord in some cases. And the existing workflow for these patients increases the strain even further, particularly for patients living in regional areas where they must travel into the clinic for this dedicated simulation CT and then go home and come back in a week or two and then finally get their treatment. Now, if you could bypass this planning CT, that would halve the number of trips to the clinic in the case of single fraction treatments, which are the bulk of treatments at Sir Charles Gairdner for palliative patients. Particularly in WA, this is significant because in 2018 to 2019, we had the second longest wait time. So the time from initial RO consultation through to the initiation of treatment, that was 34 days for 90% of radiation therapy treatment. So that's across all treatment intentions. And again, in the metric of 14 days for 50% of all radiation therapy treatments. So that saw us tied for second longest with Tasmania and New South Wales. And Australia-wide, palliative treatment intentions have the shortest wait time of 7 days for 50% of treatments, but that still indicates that there's significant room for improvement in both reducing the number of visits to the clinic and reducing the time until their symptoms are addressed. So a bit more detail on how this will be done. So first of all, I will need to acquire a retrospective cohort of planning CTs and their matched diagnostic CTs for given palliative patients. Now, deep learning algorithms typically require a large amount of data, so it could be that data augmentation methods will need to be employed to supplement a data set if we're a bit low on the data that we can access. So a study I'll talk in a bit more depth about later, they employed data augmentation where they did random translations and random rotations around the z-axis to effectively increase their number of training cases from 15 to 6,000. So that is something that could be investigated. And then once this data has been acquired and processed, it'll be time to register the images via Velocity, the image registration software available at Sir Charles Gairdner. Now, image registration is essentially about finding the optimum coordinate transformation matrix, so that is the deformation field or deformation vector field, for each voxel to transform the moving image, which is the diagnostic CT, into the fixed image, which is the planning CT. So that's what this GIF here that Bryony kindly lent me, that is what that is demonstrating. So you can see the arrows are representing how the voxels are moving from one image to the other. Now, continuing on, the registration would be done in multiple stages. So first of all, you would align the images along the spine or bony regions, and this would be followed by just correcting for the anatomy in the vicinity of the couch. So you can see in the image here on the left side, you've got that curved diagnostic couch, and on the right, you can see the changes in anatomy for the flatbed. Now, you only want to focus on where the couch is, because if you register the entire thing and extract those deformation fields, you have random changes occurring in the more anterior anatomy, which would essentially just confuse the model and acting as noise, essentially. So the main correction here is for the different couches for the scans. Now, in terms of the models that could actually be used, so the two most promising models to this end are the Deep Convolutional Generative Adversarial Network, the DC-GAN, and of course the famous UNet model, which can both be implemented via the Keras API in Python. Now, these would be guided by a loss function, which would include terms for the adversarial loss in the case of the DC-GAN, that is between the generator and the discriminator components. There would be regularization terms, and also a common loss term is the second order curvature, common in registration, to essentially ensure the production of smooth and realistic deformation fields. And once these models have been trained and developed, then you would be comparing the synthetic CTs, which are created by applying the deformation field output of the models onto a test diagnostic CT case, and you would compare that with test planning CT cases. Now, in terms of comparing the images themselves, a good metric is the root average squared sum of differences, which is for comparing intensities. And in terms of similarities with the contours, you can look at the dissimilarity coefficient and the Hausdorff distance. And beyond image comparison, it would then follow to actually create treatment plans or apply existing treatment plans using the synthetic CTs. And then you'll be looking at a variety of dose volume histogram metrics. And there is actually an example of a dose volume histogram over here, as well as the application of plans on the different CTs. So you'll be looking at things such as the V95% for the planning target volume and whether the synthetic CT plan still adheres to particular OAR constraints. So what is the status of this research? Well, I'm talking about one of several approaches to SFRT, which is itself quite a recent initiative. Since only around 2019 has it really been gaining traction. And it's most commonly seeing application in palliative radiation therapy, which I believe is likely related to in palliative radiation therapy, you are working with broader dose constraints, just given the circumstances of the patient where late tissue reactions are not as prevalent. Now, a common means of doing SFRT is just directly using the diagnostic CT, which you may ask yourself why any other approach is even considered given this. But what happens here is that there are very strict limitations put on the diagnostic CT, so it needs to be quite recent, no less than 30 days is what most studies reported. In addition, this limits the site and number of lesions that can be treated. So the most common site was the pelvis or the lumbar spine region, and typically only 1 to 2 lesions being treated. Additionally, the studies had quite extreme ways of dealing with the setup uncertainty. So some excluded any DCTs which had immobilization devices, while others went to the effort of creating vac bags to completely recreate the diagnostic position, which wouldn't necessarily be expediting the workflow if it's introducing new elements. Also, this was often limited to quite simple plans, so generally no intensity modulation, and often studies would supplement the preliminary DCT plan with a cone beam CT acquisition on couch, which in one particular study, this led to an average treatment time of 41 minutes, which isn't quite feasible for palliative patients in general, given their severe symptoms. For example, Ho et al. In 2021, they deemed only 45% of their considered patients' DCTs to be eligible. Of these, 50% were spine DCTs, and the best ones were less than 4 days old. That being said, this has seen plans produced within 5% tolerance. So when the criteria is met, you do get reasonable outputs, but there is that limited scope. And it also did manage to halve the time from consultation to treatment in many cases. Another approach to SFRT is adaptive radiotherapy. So I've again listed some studies there prominent in this area. So this is about adapting a preliminary synthetic CT plan to an on-couch scan, which has been seen to broaden the eligibility of scans which can be used. Now, the most reliable means of doing this was with Varian's Ethos software, which is online ART using cone beam CTs for essentially a scan, plan, treat integrated step. But this is, well, it requires access to this software, and yeah, which isn't necessarily feasible, particularly for this research that I'm proposing. Now, a very similar study to what I've been discussing here was by Hushan-Yajad et al. In 2023, and they developed the generative adversarial network Deep Perfects, and that has done essentially what I described in methods about outputting deformation fields, but it was done for a preliminary synthetic CT, which was then adapted on the couch. Now, the need for adaptation arose from them doing this in the context of expediting pancreatic cancer treatment, so non-palliative, and this was to improve local control. They did show this to be a viable methodology, which is very encouraging for the research I'm talking about, but there is plenty of room for improvements, particularly in how they registered their images using the open source Elastic software as opposed to something like Velocity. Now, some potential problems that could come out of this. So it's a ubiquitous problem for deep learning, as I alluded to earlier, about having access to a sufficient amount of ground truth data. In addition, limitations in computational power or just the pure amount of compute required to train these advanced models could result in some time delays, which could even urge a reassessing of the model architectures. Hushan-Yajad et al., they actually had to decrease the resolution of their CTs, which had knock-on effects for the plan evaluation. So all things to consider. Also, Velocity outputs their deformation fields in a binary format, which will require some investigation. That poses a bit of a hurdle in terms of getting it ready for the machine learning, the deep learning algorithms. Another problem is changes in patient anatomy, which could confound the model, particularly for palliative patients. Anorexia and weight loss are common symptoms, and so this is certainly a motivation behind the direct use of diagnostic CTs having a limitation on how old they could be, because part of it is if the patient's anatomy is changing significantly, that is going to have quite a large discrepancy in the plans. Also, the models produced may be limited in their scope, so it might be that accurate deformation fields are only for a specific region, in which case I would look into doing it for the pelvis or the lumbar region. Based on the other studies, these seem to be most suitable to SFRT. But of course, that would limit the range of expedition that could be done for palliative treatments. Now, ethical considerations and costs. So, of course, to acquire this retrospective cohort of data, then approval will be needed from the Sir Charles Gardner Ethics Committee. And in terms of manpower, so again, related to this acquiring of data, will be the extraction of diagnostic CTs and planning CTs from this cohort from the patient records, as well as creating or applying the treatment plans from the synthetic CTs in order to compare them with the planning CTs. Thankfully, the software is either open source or accessible, as I've somewhat alluded to, and there are ample computational resources at Sir Charles Gardner. So here's just a little timeline or a project plan, as well as something of a summary. So you can see I've color-coded here to align with the aims that I mentioned at the start. So beginning with ethics approval, where I'm at the moment, already done the literature review and things, which is where my discussion of the studies was coming from. And so then we'd get ethics approval, obtain the patient data, perform some image registration, extract and load these deformation fields, and then use that with our deep learning models and experiment with their hyperparameters using a validation set. And the best looking model out of that would then be evaluated in terms of those image metrics I was talking about, like the Hausdorff distance and things. And if that is seems all good to go, then it'll be a question of creating and comparing these treatment plans, bringing all the data together for some close analysis, and then writing up the thesis. And here are my references. Thank you all very much for listening. Do we have any questions? I'll just pop it on here.
Thanks, Joel. That was excellent. Yeah. If you don't mind, I might start off the questions.
Of course, yes.
I just had a couple. So with regards to the data augmentation that you were mentioning towards the beginning of your presentation, in your view, how important do you think it is to sort of keep those augmentations within something that would be anatomically relevant? So I guess you could maybe imagine some augmentation techniques might produce just some crazy things that aren't really anatomically relevant, whereas others might be more anatomically relevant. How important would that be, do you think?
Yeah, I think that would definitely be significant to keep it very realistic. Particularly, it'll be interesting to investigate because, as I said, we're mostly looking at correcting for the different couches. So perhaps augmentation wouldn't need to occur across the entire range of the CTs. But I suppose, yeah, you would want to keep it consistent, and particularly for things such as the spine and the bony regions, you wouldn't be augmenting them to a great deal. But yeah, that will be something I'll need to investigate further and wrap my head around. There were some good guidelines put forward by that Deep Perfect paper, which will inform that. But I think, yeah, a bit of experimentation will be required. If it's needed at all, it may be that the data that can be acquired is already sufficient.
Yeah, for sure. With that Deep Perfect model, is that available open source? Like, have they made their code available, those authors?
No, unfortunately not. At least not that I've seen. Yeah, no, I believe they're keeping it fairly under wraps, but they did go into quite a bit of detail about the model's hyperparameters and the different models they tried. So I've looked quite thoroughly through that and compared it with different papers and things and got a fairly good idea of what hyperparameters would be a good start point.
Yeah, okay. And I guess if they've described their architecture in the paper, you could feasibly just recreate that in Python if you had to. The last question that I had was, do you have, and you mentioned a few loss functions, do you have an idea of what might be the best, or is this something that you're planning to experiment with? Because I know, for example, with Brani's project, he did a lot of experimentation with loss functions, found that some performed much better than others. So I guess, do you think this is something that's important to experiment with in your project?
Yeah, absolutely. I think, and I would tailor it to the model architectures in question. So as I said, yeah, if it was a GAN, then you'd have the adversarial loss. But yeah, again, the Deep Perfects, they provided some good guidelines in the way that they were weighting the different aspects of the loss function with just like simple hyperparameters. So yeah, you could combine both the different terms of the loss function and weightings for those terms. But yeah, again, I think that would be an area of a lot of experimentation. This is sort of why on the project plan here, you can see that I've allocated a bit more of time around experimenting and training the model. I think that would be one of the most time-consuming parts.
Yeah, definitely. And one of the most important too.
Absolutely.
Great. Is there any other questions for Joel? Okay, looks like.
Sorry, one more. Sorry, just jump in, Jake. Just in terms of, you mentioned the accuracy that you're going to require. I mean, given these are palliative cases, can that accuracy maybe be relaxed a little bit do you think? And or another way of saying it, would the accuracy requirement be higher if they were radically treated patients?
Apologies, what do you mean by radically?
So where the intent is to cure. So in palliative, the intent isn't necessarily to cure.
Yeah, that is, I certainly think studies didn't explicitly allude to that or mention a specific sort of dose tolerance. But from what I was looking at, it does seem, particularly for the adaptive radiotherapy, quite excessive to adapt the plans on the day, because even the direct plans, when they were directly using diagnostic CTs, they were within the generally clinically accepted 5% tolerance. But yes, even then, I think there is additional scope, which partially, I think, explains why SFRT is mostly being done in a palliative context. So yeah, that's something that's helpful to keep in mind.
Thanks.
Bronnie, do you want to jump in as well?
Yeah, sure. Thanks, Joel. Fantastic presentation. I'm excited to see where this goes.
Yeah,
so I had a potential kind of query or concern, which I think can be addressed, but the use of immobilization devices, depending on the different site that's being irradiated, they also differ. And I know that the use of vac bags doesn't necessarily result in a flat patient contour where they sit. So that may be something you want to consider in your inclusion or exclusion criteria for the patients that you select. I'm not saying that the deep learning method would completely not be able to predict the tiny amount of sag resulting from the vac bag, but it may be the case that you'd get the best results from patients that didn't have a vac bag. So that's something to consider.
Yeah.
And also, yeah, I think comparing the deformation fields is something alongside. You may have trouble comparing, for example, the locations of organs with DICE, as you mentioned, but comparing the raw deformation fields, your ground truth deformation fields with the predicted ones would probably be the best approach.
Oh, okay. Yeah, sure. That's really good to keep in mind. You're actually comparing the deformation fields themselves. I mean, that's part of why, at least again, that Deep Perfect one, they said the reason they got their models to output deformation fields was it just sort of streamlined the whole process as compared to direct image synthesis. So yeah, I guess that also applies in the context of comparison.
Yeah. And lastly, I think if the model is somewhat workable, but not exact, and maybe there is issues with drastic weight loss or just changes in the internal anatomy that are random and can't be predicted, then what could be done is that these synthetic CTs could be used as like a baseline non-clinical plan, which can then be used subsequently to expedite the real plan once the patient does get their real or their simulation CT, because you already have that baseline plan to basically initialize, start with. So it should still speed up the overall process. So yeah, there's quite a lot of scope here.
Yeah, sure. No, I like that, because then it could be the case that it may be the same number of trips to the clinic, but reduced time until treatment. And perhaps even if regional patients, they could stay in the area for a more practical amount of time, and then still only need to come all the way in once, perhaps.
Yeah.
No, that's interesting. It's sort of similar to the adapting the preliminary plans, but without the actual rigorous adaptation.
Anyway, good job. Fantastic.
Yeah. No, brilliant. Yeah, thanks a lot, Bronnie. Yeah, great stuff. Anyone else?
Great. Thanks, Joel. Thanks, Bronnie, for those questions. I think if there's no other questions, then we'll leave it there. So you feel free to stop sharing, Joel.
Yep. No worries. Thanks a lot.
Stop the recording.